Sir, good evening, sir.
All well, Jalil sir.
Namaste, sir. Good evening.
Namaste, vanakkam.
Yesterday I couldn't join because we have a preamble meeting for Pedicon 27th.
I know.
It was
It happens.
very core meeting. I am the one among the organizing chair. So
Yes.
myself and Dr. Nandini has went there. So
No problem, sir.
I tried hard, but it was very disturbing.
Yes.
Thank you,
So
sir.
you can watch the video, sir, Jalil sir.
Please pardon me that I'm not attending the live, but I love to attend. But there is some commitment. That's why. Please pardon me for that.
No, sir. We know the doctor's problem because everybody has busy. So we are not forcing anybody to come live because we know that is why we are not forcing anybody for attendance or anything like that. And we are very much free, sir.
Honestly, for another couple of years, with your blessing and guidance, we know something. Dr. Jalil knows some AI, and he is applied this AI to his practice. That enough for me, sir.
Sir, today Arsh is going to make you how to make Jalil's custom GPT.
Hello,
It's
sir.
so good. Welcome, Dr. Harsh.
Shyam sir, welcome.
Welcome,
Good evening,
Dr.
sir.
Shyam,
Good evening.
sir.
Good evening.
Dr. Harsh.
Yes, sir.
So I will make you as a host because I have to take one more class in the another batch. Okay. Huh?
Sir, no issues.
When Gaurav comes also, you also take in. Okay. You take 20 minutes. Gaurav will take 20 minutes. And 2020 for demonstration of the new fundus device. Apart from the camera, they have a Doppler-like thing to diagnose ROP. And Mr. Jain is going to join. Okay. And also one from Autism Diagnostic Screening Tool, Diagnosis Pulkit will join. At 6:30, they are going to 6:30 they are going to join. Harsh.
Okay, sir, no issues.
Just share, allow them to share the screen.
Yes, sir.
Right?
Yes, sir.
Anything, just give me a call. My assistant Nishchita will be here only. She will be, so I can see the both the classes live only. Only thing I will make mute in order to not to disturb others. So all the workflow, everything I have for you and Gaurav I have discussed. Okay. Anything, let me know. No problem.
Okay, sir.
So on behalf of Smart Hill Nexus Academy, I welcome Dr. Harsh Bayana and Dr. Gaurav. I think they are already introduced in our AI orientation. Welcome, Dr. Gaurav.
Thank you. Pleasure.
So make sure that today RCB GT match is there. So most of them are asking me to prepone it, but I said it is in the 7:30. So we'll finish off by 7 o'clock.
Yes.
Please introduce yourself. It's your academy, not Deepak's. And please have a nice discussion with our learned partners. Thank you, Gaurav. Thank you, Harsh. Over to you. I made Harsh as a co-host. Please carry on.
Okay, sir. Thank you. Thank you and welcome all. Dr. Gaurav, we have only 20 minutes.
20 minutes to do what?
To have each presentation every minute.
अच्छा तो बाकी टाइम क्या कर रहे हैं?
देखते हैं कोई आए.
कोई टेंशन नहीं है जब तक हर्ष हमारे साथ है. नो टेंशन.
Okay, so just 40 seconds more.
जीले जिंदगी.
जा जी ले अपनी जिंदगी.
जा जीले जी अपनी जिंदगी. यस. क्या बात है.
This is Dr. Gaurav's mind.
Learners, 22 are on board now.
So what was discussed yesterday before another 15 seconds? Anybody wants to share?
Yeah, people are joining.
Any questions from yesterday's session?
It is Zoom, so
So we are with Subramania's Zoom.
Anyone?
ID. Very thankful.
I think we are only 10 people, so we can keep our cameras on also.
And Brother Subramania.
If all are comfortable. Not, that's okay. No issues. What was discussed yesterday, we'll start from there only.
From Bombay conference.
Dr. Shyam, you were there yesterday?
Bombay got me the IP software, and I started using it. And now he is a learner under me. I'm so fortunate. So
Dr.
both of
Deepak,
us have a lot
sound
of
is coming. He's
collaboration
on, I
with each
think,
other.
next. Okay.
So welcome all of you today. I think as early as by 7 o'clock we are going to finish because most expected RCB match is coming. Let's see what happens. Let the best team will win.
Deepak,
So today's workflow, dear friends, is we are going to start you how you are cleaning.
okay. So now it's under our control. So basically, I am given the topic of custom GPTs. How many of you have heard about custom GPTs in past? Anyone? Just keep on interacting so that
I
we
have
are
listened to you during PGI Chandigarh program.
okay. Great.
That was interesting.
So today I'll be discussing how to make those custom GPTs. Yesterday, Dr. Prashant must have discussed about the prompt engineering.
Yes.
I think this slide is clear to everyone that we have to use Google as a different way and ChatGPT in a different way.
Yes.
Because in Google, you are just finding the web page links, search engines, that's it. And what ChatGPT or AI is doing, it is finding those links and making a summary out of those links. So it will not just keyword search as we do in Google. We have to give it a path so that it can help you where you want to reach. If we ask questions like Google only, so AI is a information, I would say samundar. It's an ocean of information. But if you don't direct it in a way it should be directed, you will be nowhere. How many of you have this experience that ChatGPT does not give any right answer to you, but it gives very good answer to your kids? Anybody has this experience?
Yes, many times it happens.
It happens because they ask better questions. And we have to learn this art of asking questions rather than just wandering in the ocean of information. If you ask proper questions, so it's a very smooth ride in this ocean. But if you ask random questions like we ask in Google, because there it is just doing keyword matching only. But what AI is doing, it is trying to make a summary of those things which you people are asking. So if you give a prompt like write about asthma and I give you a prompt like write a 150-word explanation of childhood asthma, it will give a different thing. Yesterday, Dr. Prashant must have given you a framework of RTCF. This framework you must have got role, task, context, format and safety. It was there, Dr. Gaurav? ये हो चुका है ना?
Yes, sir. It is
yeah.
there. It was like told
He
in
had
first
a-
module. And
Yeah, yeah.
yesterday, actually, Prashant sir said in different way, but it means
Yes.
it was in RTCF for format only, but
Yes.
his format was somewhat different. He has made mnemonic like Prashant only.
Yeah, just a framework, you can use anything.
Yes.
Basically, the first thing, the most important thing, you have to give a role. When you give a role, you will reach some place. If you don't give a role, you will be wandering in sea of ocean. And then you must have clear task context. And in medicine, you must have some safety guidelines in the instruction only. So when you have to give such a big prompt for every query, how much time do you think it will take to make just single prompt? Kitna time lagega? Suppose I have to ask a question. Anything yesterday discussed which you want to discuss? Ask. कोई भी एक बताओ.
कस्टम प्रॉम्प्ट बना लेने से मुझे ज्यादा समय नहीं लगेगा. कस्टम जीपीटी या इस तरह, क्योंकि वो मेरे लाइब्रेरी में सेव है. Just I will click that and give the recordings as per the need.
So there is one option is you make a library of prompts. Prompts will start with act as a pediatric pulmonologist. and help me to manage a case of 4-year-old child with asthma in emergency. Okay, this much time you took to write a prompt, and the answer will be like this. In emergency, you have written in emergency, initial assessment, ABC जैसे हम करते हैं वो आएगा, and if you just write it in OPD, then everything will change. See, the symptoms are different, recurrent cough, night wheeze. When you were discussing about emergency, everything changed. So when you are giving instruction, you need to have
Dr.
something.
Harsh, slides are not moving. Slides are not.
Yes, slides are not moving.
It is in the what are custom GPT is the same slide. That's
Now it's okay.
Yes.
Ah.
Yes.
Now it's
Ah.
okay.
now.
Okay. So I think I should restart. So I have a patient, act as a pediatric pulmonologist and help me to manage a case of 4-year-old child with asthma in OPD. Then this is the result. Focus history, symptom suggestive. When just I change it to in emergency, see the results. So single word will make the results entirely different. So when we are doing a repetitive work, like we have to put daily notes, or we have to give a diet counseling sheet to everyone, or we have to give a make a discharge summary, you wish that this prompt should be fixed. I'll show you example how to make a prompt. I'm just discussing still prompts. So these are my custom GPTs which are basically a library of prompts. That's it. It's nothing more than that. So suppose I have to put up notes in my ICU 3 times a day. So I don't want to write every time new notes. So this much information should be given in a prompt. Role: you are a clinical documentation assistant, specialization in NICU. Your job is to convert shorthand dictation transcript into clear structured notes. Then this should be the English, this should be the output. Then I have to give structure, then I have to give examples, the output format, then the guardrails, everything. If I have to type every time when I am putting notes, is it practically feasible? Not feasible. So what I do, I just make a library of prompts which is known as custom GPT, and then I will just write I'll just show you how it works. Now this is my custom GPT, means a prompt library where I have written a draft test SOAP note for 28-week preemie on CPAP. It will make, see, in just single sentence, it has written so much. So how it has written? Because I have given it a set of instructions spanned over this much. These are all the instruction sheets. If I have to type it every time, I cannot make it standardized. I cannot use it for the repetitive purpose. I hope this is clear.
Yes, sir. Where to store the prompt, sir?
How to store it, I'll show you right now. I'll show right now. So I'll go to the initial window from where we have to start. So this window everyone is clear of? Everybody getting this window? New chat, search chat, library.
Yes.
Those who have Go account or Pro account, they will find a Explore GPTs here. How many of you have a paid account, your Go account? Do you have?
Many of us have. We have taken Go account.
Yes,
Can I use
I have also.
Can I use the phone Apple phone?
In phone, you will not get a new GPT formation. In the phone, you can just use GPT, but you cannot create custom GPT.
Yes.
So you have to use laptop. So because this is in the paid account, that's why I am going to Google Gemini, which has gems like this. Here it is gems.
Sir, if you create in your PC or this laptop, then once it is created, you can use in the mobile as well.
Yeah, then you can use it. It should be
Yes.
created in the laptop, then used anywhere,
Yes.
with the iPad anywhere. Okay, once you have made with the paid account, then when you convert to free account also, then you keep on using it, no issues. But one time you have to make in laptop with the Go account or a Pro account. So I'm using Gems because Gems is free of cost in Gemini. Everybody can use it. But most of you have custom GPTs also, so I'll start with this format only. So this is Explore GPT. You can open in your laptop if you wish to, because side by side, if you make it, then you can make later on also. Here is the Explore GPT. I hope you can see it on the left panel, just where my cursor is there.
Yes.
Yes, sir.
When you click it, here you will get My GPTs and Create. You can click either My GPT or Create. When you create a GPT, when you click on this, then you will get this kind of window. This kind of window. Are you able to open in your laptop? Please do
Sir.
side by side so that because then it becomes difficult. कि ये क्या रह गया?
Since you
Anybody wants to make some custom prompt for themselves? I'll make in front of you right now. Anyone?
since
Once
we-
again, you can try. Once again, you repeat, sir.
Okay, I'll do it again. This is Chat GPT window. Okay,
Yes, sir.
this is first window. Then on this side there is Explore GPTs. I have to click it. Here comes My GPTs. So here come the Create a GPT. So when you click on Create a GPT, you will have this kind of window. Either this or this configure. If you directly go to configure, you can just create here. Now you can just write whatever you want to make. Give any suggestion. What do you want to make? Anyone?
Research summary, sir.
Sir, prepare a newborn birth notes. Today I delivered attended one newborn. Just wanted
Neonate birth notes you want to make.
newborn birth note.
Okay. Neonate. Okay. You have to just write, I want to create a GPT for neonatal resuscitation summary. Am I right? You want to make it like this? I'll just click it here. That's it. So it will start making a prompt for you also. How it will create, I'll just show. This is stuck. So it will do automatic the background thing. So its name is neonatal resuscitation coach. And a suitable name could be, are you okay with it? I am okay. So just write okay. Now it will create a picture. You may like it or not. You can change it also. So it will like this clinical medical room, neonatal focus, this, I am just saying okay. But you can type and change it also. So what is the most important thing you want this GPT to do for users? Do you want a real-time delivery room decision support or NRP teaching exam preparation, simulate, debriefing and quality improvement, a combination? That's it. this much information you have given, what you want it to make. Okay. So it will, now we will just go to configure. That's it. It has created a custom GPT for you. See what instruction it has created. This GPT specialization in neonatal resuscitation and combined bedside decision support, NRP education, this. It should clearly separate established recommendation from, and so it has made a prompt for you. You may like this prompt or you can change it also. You can say, I want output in a format. Output should be in a bullet point format. Okay. You can say anything to it and it will create like that. So right now I am doing this only and I am creating it. That's it. Now this screen is very important. Those who are making health GPTs, generally it does not allow anyone with link. See, I have written save, but it will not save most of the time. I'll just show you. See, it could not be published. So यहाँ पे आके ना mostly doctors को होता है, सर होता तो कुछ है नहीं. Actually problem क्या है? It does not allow health GPTs to be shared everywhere. So you have to click here only me. Then it will save. See, now it is clear. You have to write only me. If it is allowing save, it's okay, but most of the time it does not allow. So I will say here, you can chat it, you can also speak here, but in Zoom generally it does not allow. So I am writing 37 week, no complication. That's it. I have given this much information. So this much notes it has written just with 2 words. You can just copy and paste into your EMR, or you can paste and put up in the gynecological file, anything. If you write 32 week required embu for 1 minute, that's it. So suppose this kind of, I have made it for the SOAP notes. I'll show you what I have made. In this way you can make so these are the instructions which I have given for making notes in my NICU. So what I do, I'll just so here I'm saying 28 week baby today will not taking. Okay, 28 week baby came in respiratory distress, intubated and planned for surfactant. This much information I have to give. It will put up all the notes for me, which I can copy and paste. See, these kind of notes are available right now. Extreme prematurity with RDS, intubated neonate, respiratory status, intubation in place, planned for surfactant administration. Only this information I have given. 28 week baby came in RD, intubated and planned for surfactant. So these kind of notes, it is already prepared. So how do I take round in my nursery? I just roam in my nursery, standing in front of a patient. I just speak into it that 28 week baby, this much, and it will put up notes. My MO will copy and paste it into my EMR. So this is the way generally repetitive things can be handled with the customized prompt. I hope this is clear. Any questions, please?
We are creating these things in our mobile or our system, and then we are copying it in EMR.
Yeah, this is clear. You can make it in mobile also. Then when you are sitting into on some laptop, you can just copy paste because it will be coming here as a history. See, suppose you rename it Reena baby. Now, next time, suppose you again open, you come next day from this window, you just open the Reena. Suppose in evening you are coming, it will open up. You can just say, now child find, put on NIPPV. That's it. Now this has the notes you have written. It will take this context and put up the notes. Extreme prematurity status post surfactant. इसको पता चल गया कि पहले क्या किया था. Now it is giving you extubated from invasive ventilation, transition to NIPPV, tolerating NIPPV. This much it has written. How it has written? Because it has taken all my instruction which I have given here. If you don't want to have output in this format, like I want this format current status. If you don't want current status, just remove this from this is current status I have written where it has to put vitals. If I'll remove it, it will note next time put current status. So you can just chat with it in a natural human language and coding is happening on the background. Similar thing, I'll again try to show. Many are OPD practitioner here. So here is pediatric diet OPD assistant. In pediatric diet OPD assistant, what I have given the instruction, these are the instruction I have given. This GPT assists pediatric clinician by generating age-appropriate dietary guidelines for children based on clinical inputs provided by doctor. It acts as a pediatric nutrition writing assistant. This GPT is intended for this. Each response should follow this structure. So this much prompt I have given. And now what I do, suppose this is my patient, 2-year-old, low weight baby, vegetarian. That's it. I have written these 4 words and it will create a detailed diet chart for this. I have written output should be in Hindi. So it is giving me in Hindi. So this, everything is ready. So all this is ready because I have given this much, this size prompt. You cannot write every time. Suppose a child is coming to you in OPD, you can just say, this is the diet chart and your receptionist sitting at the OPD counter, she can just print out from here, Kam Vajan Wale Shishu Ka Haar. She knows that child coming out of doctor's OPD is having, you can just rename it also, like I have Zoya. So when the patient comes to the receptionist, she has opened this window in his PC and Zoya diet chart, she will copy and print and give it to the patient. So your old diet chart, personalized diet chart for that patient is ready. So this is OPD use of a custom GPT. Similar things I have created for all of my work. I'll show you how many custom GPTs I have made. This is one Ayushman query answers. What happens previously? I'll show you one more thing. I'll show.
So can there be any hyper messages as far as the diet or hallucination is there, sir? Can we prescribe this to the patient directly without?
You can just see my screen is visible or not? Not.
No, the screen is not visible now, Harsh.
Sir, before saying okay, you can just have a look at it. If you have to create this much diet chart sheet, it will take at least 10 minutes if you want to explain. And when mother is coming in OPD, child is crying, You can spend 10 minutes with the mother, but she will take 2 or 3 words from you. Take my words. Not more than 3 sentences. She's in that capacity to listen. So when you give it like this, she has something ready-made at home. You can just see it, everything is okay. Then you rename it. Otherwise, you don't rename it. Patient can sit for another 5 minutes.
Can I add something, Harsh? Just a minute.
Yeah, please.
So this is a wonderful question, Dr. Jalil. I'm so happy that you've asked this. I have a GPT which is exactly very similar. The last line says that if you find any problem in the chart, please contact, and then I've given my clinic number and said Dr. Gaurav Gupta. So the point is that at the end, I've given a disclaimer saying if there is anything which you find unusual in this chart, if there is anything that you find, and that will come at the end of every chat GPT generated, AI generated. So if you see, even Google says that, notebook LM can make mistakes, chat GPT can make mistakes, AI can make mistakes. I think we should make it a habit to write it at the bottom of our, GPT. And I think it's a wonderful thing. And of course, Dr. Harsh is very right. We should also, first check before we share. Thank you.
See, that's what is the safety prompting. That's why
Yes.
role, task, context, and last is S, which is safety. Okay, these safety guardrails are must. I believe no AI should be given to the patient without human in the loop. So when you are making it, you just check it before renaming it. As I was showing my Ayushman query wala, so these used to be my OPD notes 6 to 12 months back. I think everybody has these kind of notes.
Yes. Yes, sir.
How much time do you take to put this kind of notes? At least 2, 3, 4 minutes per patient. If you
Yes.
have 10 patients in your NICU, at least 1 hour you will go for putting notes 3 times a day as per NABH requirement. Now my notes are like this. And no TPA insurance company asks any questions from me because these are so detailed, nothing like that. And moreover, what my team is doing, I'll show you one more thing. Suppose this is my Ayushman query answer GPT. What I have instructed in this GPT that any discharge paper before being submitted to insurance company, they will first check it here. Review this discharge summary. Okay, क्योंकि एक बार upload कर दिया discharge summary, then they will just put why this is not, why this, and every time I cannot check it. I have 30 bed nursery babies lying there, and when you have done everything and then the insurance company says no, you have not done it clearly, 30,000 deducted. So it is very painful thing. So before submitting, any patient can get review of this discharge summary, and if I get any queries, most of the time this is my query, justify a prolonged NICU stay. So my TPA guide does not disturb me for this. They will just put in there, it will make a detailed answer to that question, and I have not answered to any insurance query for last 6 months because of this GPT. It saves at least half an hour of me and a mental torture of me when you feel like कि मैं तो सब ठीक कर रहा हूं, ये बार बार क्यों पूछते रहते हैं. So these things can be handled with the help of these kind of chat GPTs. These kind of custom GPTs. So I have made it for n number of reasons, everything different for different surgery notes, different diet OPD assistant, surgical consent I have different. Then my IVF center, उसके अलग से, हर चीज के अलग से custom GPTs हैं. Even my hospital details in the form of a QR code are a custom GPT. Like I'll show you your companion to fertility journey. So this is a custom GPT which I have link made as a QR code and sitting outside the operation theater. So people can ask how much time hysteroscopy will take. So it will tell generally 30 से 40 मिनट में पूरा हो जाता है, कुछ मिनटों में 1 घंटा भी लग सकता है, या इस बात पे निर्भर है क्या करना है. So this is the information I have given. Now where to give that information? Now I will show that thing. I was showing the instruction sheet. This was the instruction. I think instruction part is clear. These instruction can be changed whatever you wish to have. Then just below the instruction, there is a knowledge base. This is the knowledge base I have given to my SOAP note builder, where I have given PGI protocols, Cloharty, Gomella neonatology. Based upon that information, it create notes. Similarly, where I have given this thing, I have given instruction based upon my own documents which I have prepared, based upon the patient queries generally we get. This is what FAQs I have in my hospital. Most of the patients are asking. These are the FAQs. Like this document I prepared. I'll show you this document also. What is the success rate? ये क्वेश्चन ज्यादातर पूछते हैं हमारे यहाँ से. So इनको मैंने knowledge base बना दिया उसका. So from now the custom GPT will reply from this knowledge base only and with this instruction only. So you can create it for your things, the small things. As sir has said, I want to make it for the neonatal resuscitation. You have to just make these instruction in such a way that it put up notes. That's it. I hope, Dr. Jalil, it is clear.
Understood, sir.
So these are the things to make custom GPT, and similar is the with Gemini Gems. Gems is almost same. That is free of cost, but just I am more tuned to custom GPT, so I am showing here. But these things are similar in Gemini. I'll show you there also. This is the Gems I have made for custom pediatric OPD helper. I'll show you one pediatric OPD helper because Gemini is better in understanding the English extent which I am chatting with the patient. So this I have made in Gemini. I'll show you one recording also. Upload file. So suppose I have a random recording, this one. I'll show you first what is the recording. Then I hope you can better understand. So I have taken a random recording here. Sound is audible? System sound. System
No.
sound सुन रही है?
Yes,
No.
very much.
No.
Okay, I'll share. खांसी भी है. Now system sound is audible?
Yes, sir.
This is the routine talk what I am doing with my patient. खांसी है. Quality is such a poor quality. I know you will not understand anything, but Google Gemini can understand it. जल्दी आ जाता है. So the same recording I have given to this, and I have said in transcribe it. The same recording which I was making audible, आपने जो सुना, this says extracted information from it: fever for 3 days, mild cough, throat discomfort, mouth breathing. This was all information being delivered in this chat. Am I using it? No, I am not using it right now because in our practice, most of the time we don't speak the prescription and all those things. But this is possible if someone likes it, can use it. So these kind of GPTs we can make and use. These are the custom GPTs and gems. Other gems are also I have made for other things like IVF counseling, NICU counselor. NICU counselor is one another where I just put up the recording. Like I'll show you one recording. See, counseling for IVH. If I just give this much information, Do it. That's it. इसमें क्या सुना मैं आपको सुना देता हूं पहले.
ये बच्चा 28 हफ्ते का हमारे पास आया था जी. इसको पहले 2 दिन कोई ब्लीड नहीं था. आज सुबह जो रूटीन अल्ट्रासाउंड किया है उसके अंदर इसमें ब्लीडिंग आई है. अब इस ब्लीडिंग की वजह से हो सकता है बच्चे के दिमाग पे असर रहे.
This kind of counseling we are doing in routinely in NICU. Everybody must be doing it. And after 2 days, patient comes back to you and tell you, sir, आपने तो कुछ बताया ही नहीं था. Does it happens? So whatever you have talked to the patient, you can just transcribe it without doing much mehnat. This kind of counseling will be there. You can pull out this sheet, give it to the patient. Patient can read it, sign it, then comes back. You can have it in the Hindi also. Give it in Hindi. So it will give it in Hindi also. Whatever the instruction I have given based upon that, it will create right now in Hindi. हमारे पास 28 हफ्ते की समय से पहले बच्चा आया था. शुरुआत के पहले 2 दिन में बच्चे की जांच में ब्लीडिंग की कोई समस्या नहीं थी. आज सुबह जो रूटीन अल्ट्रासाउंड किया है उसके बच्चे के दिमाग के अंदर ब्लीडिंग है. नाउ यू कैन जस्ट कॉपी, प्रिंट, गिव इट टू द पेशेंट, आस्क हिम to come back after 1 hour after signing it. So if he has this much consent form and it is there in your file, you are medico-legally safe, you are otherwise I think safe, so you can use it if you want to use it. So these kind of things can be done in your practice. So that's all from my side. If any questions, I will be happy to answer.
Harsh, can you once more show how you created that diet, that thing of how you created that custom GPT of diet for the pediatric diet?
Okay, sir. So
what
this
are
is pediatric diet assistant. I have given the instruction like this.
Because we want to know how the instructions you have given.
This GPT assists pediatric clinician by generating age-appropriate dietary guidance for child based on clinical inputs provided by doctor. Now, this much prompt, it is difficult to write, I know. How to write these prompt? Ask from ChatGPT. I'll show you.
Okay.
I want to make a ChatGPT custom for pediatric OPD diet counseling. Make instruction prompt for me. It will create a detailed instruction prompt.
Okay.
See. Now you can edit it in the way you wish to have it. You can just copy and paste. That's it.
Okay.
You can also give the prompt that it is a South Indian child or Punjabi child.
Yeah. So I have given here, it should be North Indian, Haryana child where I'll show you. See, diet example should primarily use common North Indian household food like this. You can just write South Indian food also.
Okay.
I just wanted to know one thing, that when you are asking for this kind of a diet, do you give any medical literature to support it, or it just looks in the internet and gives the answer?
You can put up, see, here I have put books. Nutrition chapter, IAP textbook. ICMR guidelines, pediatric nutrition, child nutrition, all these are books basically. So you can put up this knowledge base. So
I think we can.
So PDFs of books you upload.
Yeah. See, these books I have uploaded.
I think we can upload up to soft copy of Nelson as well.
Sir, see, these you can upload 50 documents, but one document preferably should be 300 to 400 pages only, because it does not have that power to read more than 400 PDF. Context window is a concept in AI where it cannot read bigger documents.
Hardev is more than 400 pages.
Better to be less, because I have uploaded Nelson and all those things, but generally it is not able to read those things, and moreover the figures, if they are coming, it does not understand the figures, it will understand the text and tables like this. The जितना फोकस रहोगे उतनी बेटर एडवाइस आएगी, जितना ज्यादा डाल दोगे उतना जनरलाइज चीज हो जाएगी.
Okay.
So where will we get such focused literature? Like if we want him, the ChatGPT, to get
The best literature is your hospital's protocols. The best literature is just sit in OPD one day, keep your mobile open, allow it to listen to you, because you want it should create what you are talking. You don't want any book also. So the best part is just keep a mic open in your OPD, let him listen from morning to evening, and next day just transcribe from whatever you are speaking. This is the best way, I believe. I hope it is clear.
So you mean to say that when we are, suppose I am seeing a patient, I'm seeing a lot of small newborn babies with their various problems. So every time I get a patient who's less than a month, I put my mic on in ChatGPT and let it listen to.
You just put up your mic on. Like I'll show you. I'll show you. There is a. So my screen is not visible. My screen is visible.
Yes, it's coming up.
You just type sound recording. So everyone laptop has this sound recorder app in their laptops. Okay.
Yes.
Most of the time, these are all recording. I am recording for patients and all those things. You just start a recording. Now it is listening to me. Keep it recording. सारा दिन इसको सुनने दो. जो आपकी बात आएगी सुनने दो. वो जितना आपका रिकॉर्डिंग निकल के आएगा, बाद में जेमिनाई को बोल दो मेरी बातें निकाल के दे, वो निकाल के दे देगा. That's it.
Oh, that's interesting. Okay.
मतलब you should be speaking. Am I right?
Yes.
So just keep a mic. This is my mic. Somebody is asking which mic. This is my mic I am using, Jabra mic. This is around 19,000. It is sitting in my table and it is listening to me. If it is 2 feet away from me, 1 feet away from me, 3 feet, it has a beautiful capture of my voice, background cancelling, and Google understand it's everything. मतलब मैं कुछ भी बोलता हूँ इसको समझ में आ जाता है, कितना भी दूर पड़ा हो. अभी मैं अपने पास रखा हुआ है ये, अभी मैंने इसको 3 फुट दूर रखा हुआ है. आपको मेरी आवाज आ रही है?
आ रही है.
So this is the beauty of this mic.
Okay.
Please ask more.
So that is how it will customize to my advice.
Yeah, that is the best thing, because literature, internet is full of information. I wish कि डेंगू में मैं 10,000 प्लेटलेट पे नहीं चढ़ाता प्लेटलेट. This is my thinking. I don't know I am wrong or right. This is my thinking, and I believe this should be delivered to my patients. So that is the best thing. Your hospital protocols and whatever you are speaking is the best knowledge base.
Okay. But at the same time, if 300-400 page document you have, I can upload that.
Yeah.
Okay.
So, thank you, Dr. Harsh.
Thank you. That makes it very clear.
Thank you. So that ends my talk. If any questions, you can put up in the group, and I'll share one document also. Just Dr. Gaurav, 1 मिनट और ले रहा हूँ सिर्फ आपका.
Jitna Marzi, please take your time. Yours is the more exciting.
I'll share the steps how to make custom GPT. I made a document also, so I'll share with you in 2
You can
minutes.
put it in
Share
the
in the
WhatsApp.
WhatsApp group.
Yeah, put it in the WhatsApp, Harsh. That will be better.
Yes, sir.
John
I-
McCarthy. Rupal.
I am just sharing in the
WhatsApp.
done. It is done. My file is there in the chat box. You people can download it. All the instruction I have given you in a stepwise manner, everything is there. This is part of a chapter which me and Dr. Gaurav are writing. Book, उसका chapter है सर, मैंने लीक कर दिया. But I think ये मेरा topic था, मुझे बताना पड़ेगा.
Yeah. बुक का लिंक भी डाल देंगे एक बार जब बुक रिलीज हो जाएगी.
अरे सब फ्री है सर. हमने कहाँ से लिया है? यही से लिया है. हमारे पास कौन सा था?
So thank you, Harsh. It's been wonderful as usual, listening to you. I'll start sharing my part of the. I think you need to make me the co-host, I think, because it's not allowing me to share. Yeah.
Done, sir.
Yes, thank you. Okay. So there are a few things that we have to discuss, and it's a little more technical this time. We are going to be talking about, I hope my screen is visible now. Yeah.
Yes.
Yeah.
Okay. So we are going to be talking about something which is right now slightly theoretical. On the other hand, this is going to be the future, and that's why Dr. Deepak has specifically even asked, some AI experts to chip in and actually do an actual demo of their product also. So this is not the present, but this is going to be the future very, very soon. And what are we going to be talking about? Screening, diagnostic, and monitoring tools in which we are using AI to make something which can be used in our practice. So we will be focusing on tools which are currently happening and which will happen in the near future. The background here is that every day, every month, every year, we have more and more tools which are being validated and which are being used in various medical platforms. So software as medical device, SAMD, is a new category of tools, which basically means that you are using a software which is created using some AI algorithm, and you are using it to actually screen, diagnose, monitor, and treat a patient. So how does this work? This is going to become more and more common. How it is going to affect our workflow in the future, and most importantly, if we go back with one thing, that would be, how do we know that a tool can work for us? That is the gist of my presentation. It should not take a very long time. And then we'll have a demo, as Dr. Deepak has said, by one of the people who have actually created the hardware and software for doing this. So let's begin. Okay. So in the chat, can you guys just mark if any of you have this problem? You are sitting in your OPD. You have 10, 20, 30 patients or even more sitting outside, and a new patient comes to you. The mother says, my child has speech delay. My child just doesn't talk. And you see that the child is not communicating with their eyes. He's not looking at you. He or she is straight away going and playing with the toys. Now you know that ideally you need to do something like an MChat screening. Maybe in a 2, 3-year-old, 4-year-old, MChat will take 10 minutes. And unfortunately, यहाँ पे Dr. Harsh can, the protocol of giving a counseling sheet will not really work, because once you do this test, you'll have to explain to the mother or the father as to what is this speech delay. Is it an autism spectrum or not? Which means 10, 15, 20 minutes gone. You can't afford that, right? In terms of the patients. So what do? Problem number 1. If you have experienced that, please type 1 in the chat box. Problem number 2. You have a NICU, You have, like Dr. Harsh has some 30 patients in his admitted at any time. You have done your NICU soap notes, and the child has gone home. You have told them that this baby needs an ROP screen. They come back to you and they say, and then you see that they have not done the ROP screen. Problem number 2, the nearest competent pediatric ophthalmologist is 80 kilometers away. What do? If you have faced this problem, I would like you to put number 2 in the chat box. These are time and access problems, which all of us will face to different levels, depending on where we are, tier 1, tier 2, tier 3 cities. The good news is that AI has some answers. I won't say all the answers, but it has some answers. And thank you everyone for joining in and putting it in the chat box. Great. Okay. So we lose children because we are not screening them. We lose children because we don't have specialists. We lose children because parents are not coming. They have spent 50,000, 1 lakh, 1.5 lakh seeing the baby in the NICU. But afterwards, when it comes to doing a vision screening, doing a hearing screen, they just don't seem to understand the importance. And documentation burden is a problem, which yesterday Prashant, today Harsh has clearly demonstrated. The important thing is, once those charts are created, somebody has to review them also. Once you have a 30-page summary made by AI, somebody has to go through them also. So these are the gaps. Sorry? Okay.
We lost your voice.
All right. Sorry. Am I audible?
Yes, Gaurav.
Yes, now you are.
Wonderful. All right. So Dr. Deepak told me to look it into 3 parts, and I'm going to focus on these 3 only. The first part is screening or triaging. The second part is imaging or decision support. And the third part is monitoring. So we need to understand a problem before the symptoms are obvious. If we miss autism, then the child needs far more aggressive therapy, and they may become a burden on the society, on the parents, on themselves once they are older. We need to understand imaging, and I think we'll be having a demonstration by the Trinetra group later on. We need to understand that sometimes we may not have an expert right at our center, but if we are able to catch the correct image and send it across, then it can be done in a telemedicine form also. Of course, AI tools can also help us do this. We'll be looking at that too. And over a period of time, we need to look into subtle changes which can be missed. And I think one of the most important thing here is growth faltering. And we have seen so many times that once we do a proper growth chart, the child has come to us from some other place, and we do a chart, and then we see that the growth has actually gone beyond 2 lines. It has come down beyond 2 lines, or nowadays it's gone above 2 lines, in which situation you end up with children who are having failure to thrive or severe obesity. I personally have missed children with celiac disease because of the fact that their growth chart was not done properly. And I'm sure many of us have seen this. Of course, in an ICU setting, you also need to look at things like sepsis screen for crashing patients, and various other kinds of things in which AI can help you. So in Hyderabad, I was told this, that they have a Asian Institute of Gastroenterology, and in that institute, they have actually reduced their code reds and code blues to practically 0, because they have continuous monitoring of the vitals of any admitted patient, which is fed into the AI model, and the AI model helps predict which adult, which gastroenterology patient may be likely to crash. Now imagine if we had this in our setups, how much easier, how much better, how much more likely were we to pick up these things, because all of us have experienced children who have suddenly crashed. We think they have crashed suddenly, but actually they have not crashed suddenly. There are subtle signs which we have not monitored, and those signs are picked up if we are using AI screening. So I will not go into huge details of these things because most of these models are experimental. They are not validated. We'll look into a few. We will have a demonstration after I finish. But most importantly, my take home would be, how do you know if a model, if an AI app, if an AI software and hardware is likely to work in your setting? That is the goal of this presentation over the next 20 minutes. Okay, so this is one tool. It's called AI Gnosis. What it does is that it looks at webcam-based behavioral analysis. It can be done at two levels. It can be done at a clinic level. It can also be done at a parent level sitting at home. It is non-invasive. It has been tested for on Indian children, and it is a promising tool. The important caveat here is it's a screening tool. It is not a diagnostic tool, and it will risk flag your child saying that this child requires this kind of further assessment. It does not tell you that this child has a diagnosis of autism. The interesting thing is you are sitting at your home, you have a laptop, you have a webcam, the child is talking, there is no distractions, you do a few things as told by the counselor, and with the video, the AI analyzes and tells you whether your child may have autism or not. Similar tools have existed in US for a fair amount of time, and there are clinically validated FDA tools for trying to diagnose autism in the Western population. In Indian population, this is a very, very promising tool. It is a triage extender. It is something which requires more validation as per the information which I found on the website. This was a tool which was shared by Dr. Deepak. The important thing here is it is an amplifier. And if you tell this child who was sitting in your OPD, look, let's do a complete video analysis, let's look at this data, and then let us see whether your child may have features which can put them on the autism spectrum. You may be able to save some time for yourself, and a child who's sitting at home may be in a more natural state of affairs, and they will be able to easily pick up these things, because in the clinic, the child is stressed, the parent is stressed. If you are in a busy OPD setup, even you are stressed. So this is one thing. I will not spend more time on this one. This is a very interesting one, and we will be having a practical demonstration of this, which I am also looking forward to. This is something by Fortis Health called 3Netra. What is this? It's a portable handheld neonatal retinal camera. So the nurse or the neonatologist or anybody of us, we pick up this camera, we place it on the eye of the baby, and without any specialist available, we are able to capture images of the eye in very high resolution. These images are transmitted via telemedicine to the ophthalmologist, and the ophthalmologist sitting 80 kilometers away or wherever can help diagnose this particular child. Now, the important thing here to understand is the demonstration would be done, but the important thing here is, please understand, this part is not AI. The digitization of an image is not artificial intelligence. The telemedicine, sending the image from your neonatal setup to a specialist sitting 100 kilometers away, is not AI. Of course, the imaging itself is also not AI. Why I'm saying this is, we are doing a course on AI. We need to understand what is artificial intelligence and what is subsets of artificial intelligence. All of these things are extremely valuable. In fact, taking a high quality image is actually the key for making this diagnosis. My wife is an ophthalmologist, and when I showed this slide to her, she was very impressed. She said it's very, very difficult for even a good ophthalmologist to take a good image of a retina. So she really wanted to see this demonstration as well, how a neonatologist or a nurse can do this. So the image is the first part. The digitization is the second part. The telemedicine is the third part. But none of this is actually AI. Where does AI come in? AI comes in the next picture. So once we have captured this high resolution image, we have democratized the entire setup. We do not need somebody sitting in high level specialist sitting inside the NICU and doing the screening. Then it can be analyzed by either a pediatric ophthalmologist or certain clinically validated AI tools. So there are multiple tools which are available in the West, like IROP. They can look at the ROP zone, they can look at the stage, they can look at the plus disease, and they can suggest the urgency of referral. Of course, AI can make mistakes. Human in the loop is important. And eventually, if there is any doubt, you must have a pediatric ophthalmologist available. But this part can be democratized, and it is very, very useful, especially in normal eyes. If the AI says that the eyes are normal, if the tool is clinically validated, then there is a very good chance that you can save multiple visits to an ophthalmologist. But the important thing here is to know which part is AI and which part is not AI. So this is probably the most important slide, the slightly fun slide, which I call the pediatrician's AI bullshit detector, the BS detector. So let us say a random vendor comes to us with an AI tool. We are all very impressed with AI. We have done a very good course. We are all smart academy pediatricians now because we've done a smart course. So the vendor says, my tool has got 97% sensitivity. My tool, which I'm going to give to you, is FDA cleared. It is FDA validated, and it will reduce the missed cases that you have by 40%. What does that mean? What are the questions that you need to ask in such a situation? That is something that I would like maybe anybody to tell me, anybody who's online, Dr. Jalil, maybe Dr. Aruna ma'am. If somebody says I have a 97% validated tool, I think both of them have their mic on, so I'm asking them. But anybody, what is the first thing you want to ask them?
Sorry, sir, no idea. Sensitivity.
No idea. So the important thing is, the first thing we need to ask them is that what is the population that we studied this tool on? Because most of the tools have done their studies in US, Europe, and in India, the population may be very, very different. Our staging of the disease may be very, very different. So where is the sensitivity? Where is the specificity come? I think that is extremely important for all of us to understand. The other thing which we need to understand here is, when they say FDA cleared, FDA validated, CE approved, what does that mean? If it is approved as a screening tool versus if it is approved as a diagnostic tool. Most tools, like for example, the autism screening tool is used only for screening, which means it is not going to give us any diagnosis. It will just flag saying this person, this child is a high risk for autism, like our MChat. After that, we still need to go to a specialist, to an expert, so that we do not miss this particular case and we do not make a misdiagnosis. So FDA approved for what? Screening or diagnosis. The third is 40% reduction. And this is something which is, like I love vaccines. So I always think of vaccines example. When we say 40% reduction, what is the comparator? Is it a placebo?
Yes.
Is it a different vaccine when I talk about vaccines? So in this situation, when we talk about AI, we must look at what is the reduction compared with. Is it compared to an absolute risk reduction? It is a relative risk reduction, and what kind of baseline data they have. So when we look at this particular tool also, where we're going to have a demo now, we must understand that these questions need to be answered by whichever AI vendor that we have coming in. This is important primarily because not today, but tomorrow, we will have more and more AI tools coming in. Today, these tools are present, and I have personally seen these tools being used by adult physicians. We have a very leading endocrinologist who's practicing in Chandigarh, and they have a tool for doing screening of the eye using AI. So they have an indirect ophthalmoscope. It is connected to AI, and they just take a picture using that, and that image straight away goes to the center, and the center will report it as normal or abnormal. If there's any doubt, then that image is given to an ophthalmologist. The ophthalmologist will review that image, and then they will call back saying that this patient has diabetic retinopathy. Adult physicians have already started using these types of tools. In pediatrics, we have less data, we have less validation, but if not today, tomorrow, these tools are going to come in. So I think this is a very, very important slide for us to remember, that how do we know whether the tool is likely to make sense in our practice or not? So coming to the last part, which is how to judge the tool. Again, it is based on the bullshit detector part, which means that please ask 4 questions. The first is, where was the validation done? Were Indian children involved? Again, I use the example of vaccines. Nowadays, it is mandatory for all vaccines to be tested on Indian children, at least to get the antibody titers before we start using it. Same logic applies to AI tools. We must have some testing on Indian children. What is the output? Now, this is important because the output is what is going to determine what is going to happen. So whether the output is going to be flagging this child may have autism, whether the output is going to be a diagnosis, this child has ROP grade 3+ disease, and then how does it support the decision? What is the next step? Who carries the clinical responsibility? So once it flags, how do you decide? If after flagging a diagnosis of autism, I do not have any neurodevelopmental pediatrician or autism expert available for referral, then there is no point of doing the screening. Because eventually our goal is not to buy or use an AI software. Our goal is to make sure that the child gets attention early for any disease that they may have. So that comes to point number 3. Who acts and how? What happens after there is a positive flag? For ROP screening, you must get a pediatric ophthalmologist. For a diagnosis of autism, you must get a neurodevelopmental pediatrician into the picture. And finally, and this is extremely important, not only from my perspective as a pediatrician, but from the parents' perspective. What are the false positives? If I'm screening 40 children for autism and I'm saying 20 of them need to be referred for evaluation, what is the amount of anxiety that the parents will have? What is the amount of cost it will add to their entire getting it diagnosed, getting it ruled out, and how much of that is true versus how much of that is false positive? Similarly, what is the false negative? Which means, are we going to miss children? This is very, very important, especially in an eye condition where you might lose your eyesight and become blind, because at the end of the day, the responsibility will never lie with the manufacturer of the tool. The responsibility will always lie with you and with me, because we are the ones who are using this tool. And finally, this is something which requires an entire lecture on its own. I don't know if Deepak has put one here, something called de-skilling. De-skilling basically means that I start treating AI as God. If AI has said this, then it must be true. I hope all of us, being a part of Smart Academy, realize, and I think Dr. Jalil had asked a very nice question that time, what if that there is hallucination? Please remember that we must apply our mind. The human has to be in the loop. Otherwise, we end up in thinking AI is God and we end up with de-skilling. So that should not happen. So last slide, how do we start AI in our practice? Start with the most common use case. Are you more likely to see, for example, in NICU, children, very, very low birth weight babies? Then you may be looking at Trinetra kind of a tool. Do you see a lot of post-COVID children who have a lot of digital screen time like I see in my practice? Probably something like an AI diagnosis tool might be more appropriate for me. Pick the gap that hurts most, define a referral threshold before, try it on 20 to 50 cases yourself. As Harsh told, you need to have local data for prepping your chat GPT, custom GPT. You also need to have local data for prepping your AI model. See how many false positives you are getting. That is very important because it creates a lot of anxiety. See how many negatives you might be missing before you decide that the tool may be acceptable. And of course, you need to know the cost. You are the person who's the validator, ultimate validator for your own setting. So this is all about the tool. We are looking at a very exciting future. I have not listed, Deepak had sent me a list of probably 20 tools, but I have not listed them. I've just given you 4 or 5, but I'm sure there are many more which are literally, on our doorsteps. We have AI assisted pediatric ECGs for arrhythmia monitoring. We have growth monitoring AI already available. Neonatal sepsis models are being routinely used in the West. AIMS, PGI are also in process of developing certain neonatal sepsis models and even PICU models. Seizure detection can be done even by the Apple Watches and similar things. So all of these things are coming today and tomorrow. I think this class was primarily to engage you, to excite you, to make you aware that this is the future. AI is going to be there in more and more scenarios. We need to be aware of this and we need to know the right questions to ask. So the question that matters is which tool will reduce missed children, save specialist time, and are safe for my setting today. With that, I thank you and I'm open to any questions that you might have on this, after which we can certainly go and have the demonstration of the tool by the team from Trinetra, I think. Any questions? Yeah, Dr. Sham seems to have his hand up. Yeah, Dr. Palaniraman.
Dr. Gaurav, at present, any specific AI tool and your experience? Now you are practically applying in your OPD clinic, OPD setting.
So I have no personal experience of any AI tool which is clinically validated. I would like Harsh to also chime in on this. Yeah, Harsh, please.
Sir, Arvinda Eye Care, आपके साउथ का ही है. They are using it for diabetic retinopathy.
Yeah, of course. That I said in the talk itself that the adult diabetologist, even one in Chandigarh, they have a indirect ophthalmoscope, which is maybe it's the Aurobindo Eye Care one, but they are using it. But in pediatric, I'm not aware of any validated tools which are being used.
Harsh, anything you are using? Harsh, anything you are using?
So just to add, you all might have heard the news about AIMS in Delhi, which have started using a model, AI Doc or Cure AI. It's a radiology model in which what they are doing is they are looking at all the 1,000 X-rays which are done daily in AIMS. And
tuberculosis screening, yes.
Yes. So they have started doing this, and what they have done is out of those 1,000, they say 900 X-rays are so-called routine X-rays done before, any eye surgery or any this thing and that thing. And what they have done is that their workload has decreased by 10x because only 100 X-rays are now referred to the radiologist for actually evaluation. The radiologists are happy because they don't have to look at 900 normal X-rays. And the AI is actually making sure that there is not extra load on the radiologist. This is not a pediatric specific tool, of course, but this is the future, as far as I understand, of AI once we have validated Indian models. Yeah, please.
Please. Sir, I have heard that people are using growth chart on AI basis in Delhi.
Yeah. So of course, I mean, you can use growth charts and there are growth chart tools. I'm not aware of any commercial tools, but I would be happy if somebody finds some information, please post it in the WhatsApp group, because growth chart is something which AI can very, very easily do, and they can detect once you put it. I'm sure an app can be made very easily using some sort of vibe coding to create this. I think it's an interesting idea. In fact, we should look
Dr.
into
this. The doctor who presented here in our city regarding this growth flattening, she was telling that we are using in leading heading, I think, about this thing.
Wonderful. I hope they're validating it, but you are absolutely right. Growth chart, we have mentioned it in the slide also last slide also, that growth chart monitoring is a very, very low hanging fruit because it's easy to pick up even for us. It's for AI to pick up is even easier, and picking up children with significant obesity, picking up children with significant FTT. So I think it's wonderful that they're doing it.
I just wanted to know that since 900 X-rays are ruled out as normal, is there any way of finding out if amongst those 900, they have missed a few which are not normal and added them there? What is the probability of that?
Yeah, so wonderful question. I'm so happy that we are getting these questions. I was really impressed with the question Dr. Jalil asked about hallucination, and ma'am, your question is
I'm
exactly of the
about to
same
ask that
importance.
question, sir.
Yes. So, Dr. Sunita's question is so important. What is the chances of missing a positive case using AI? And if I know correctly, that the doctor who has done this entire trial is based in Ashoka University. He's a radiologist. I think Harsh probably knows him. So they did almost, if I remember, 3 to 5 years of work using their own models, and that model was consistently replicated. The data showed consistently that the number of false negatives was extremely low. And even then, they took so much time to actually allow that model into clinical practice. So the chances of this model being wrong are far lesser than an actual radiologist being wrong. And after that, this model was actually introduced. If Harsh has something to add, that will be great too. Yeah.
Sir,
Sir,
the AI,
I
what
can
we are discussing, seeing daily, is generative AI.
generate.
What now Gaurav sir is talking about is the traditional machine learning and deep learning models. These machine learning models are there existing since 1990s. Deep learning came into 2012. So these models are quite accurate for the things for which they are developed. It's not a general kind of thing. Like X-ray reporting things, if you are asking me, it is whether normal or abnormal. That's it. It is not telling anything else. It will not tell it is tuberculosis, it is empyema, it is XYG. It will just tell normal or abnormal. Based upon what things it is telling, it has seen millions of images of normal X-rays. Okay, how do you diagnose a normal or tuberculosis X-ray? You have seen maybe thousands in MD, then more 5,000 during your practice. You have seen 6,000 X-ray. On that basis, you are saying that this is normal. Okay, and these traditional machine learning and deep learning models have seen thousands or millions of X-rays. So the chances of error is very less in traditional machine learning models. But the hallucination part, see, the sensitivity, specificity, they have to prove. But sir was telling that Arvinda Eye Care, the diabetic retinopathy is being reported because they have seen millions of images. Why not there in pediatric? Because the image acquisition part, as Dr. Gaurav was stressing upon, we need the peripheral window. In diabetes, they need a central part because they need a central retinopathy. हमें क्या चाहिए? Periphery. कि vessels आ रही हैं कि नहीं आ रही है. And that image acquisition is a very difficult part. That's why in neonatology, for the ROP part, no model has reached till that level. But technically, if you say if you are able to get those images, it can be done very easily. But the image acquisition is the difficult part. Okay, it is about the ROP thing. Then you are asking what are the tools which are in current use. These are basically MLDL tools which are inbuilt in the machines only. Like CT scan in your hospital must be recording, they are flagging the abnormal part.
Like
They are
CBC
already
machines also.
in CB, all these machines already have this technology in the machine. Suppose a radiologist, how many films he has to see to give a report of CT chest? How many what do you think? 20, 30, 40? It has to see, and it has to see in detail, and it has to report 10 CT scan in his 5 hours duty. Do you think he will see every report with every detail, everything? Can you see it? Or a pathologist, he has to see 100 slides. Everywhere he can put his mind and see everywhere it is normal, 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 normal. It cannot do it. So what the AI tool does, it just flags it that in slide number 33 in 9 o'clock position, just go and see because it is looking slightly abnormal. This is traditional AI which is working in machines very good. It is not reporting, it is assisting pathologist and radiologist and any image capturing image interpreting physicians basically. So this is traditional medicine. Now comes to the hallucination part which you were talking. So the sensitivity and specificity part, it is for every test. Okay, you even for BCG, for typhoid, for traditional Vidal, everything has specificity, sensitivity. The point Gaurav wants to stress that you have to keep a watch on the biases. The model trained on US population will not do for the Indian population. So when you are questioning a guy who is coming to you with the ML model, with a DL model, you ask who was the source data, from where he came. Suppose you are using for something skin in a South India and the data is from North India. Just ask भैया फिर से मिलते हैं. You get a data from your patients. Okay, this is the bias thing. That is the machine learning part. Just I want to combine it. Don't confuse it with the generative AI. Okay, generative AI is completely different thing. Yes, sir.
Yeah.
Dr. Jalil.
One small example I just wanted to quote, whether I am right or no. See, when we are waiting in the security check in the airport, we are waiting for our luggages, whether the screening done, and if it is goes to the green signal, we are happy. If it go to the other way around, then we find it difficult. Similarly, the 1,000 X-rays undergo this kind of a screening, and this 900 normal X-ray go to the green signal, and we can declare it normal.
Yeah.
Like
Absolutely.
So
Yeah.
the thing just to take this is that just like you will be doing tests for any particular medical thing. For example, let's say you are doing for Vidal, you will be looking at the sensitivity and specificity of Vidal. You will be looking at the sensitivity and specificity of ceftriaxone for treatment of Vidal. All software as medical devices, SAMD is the technical word, would go through exactly a similar procedure. So to answer ma'am's question, if you would have the doctor sitting in, if you would have radiologists sitting in evaluating 1,000 X-rays, and then you would be saying this is the number of cases that they were true positive, true negative, and of course there would be false positive and false negative even if a doctor is doing it. Similarly, all software as medical devices will be checked. And very, very important point made by Harsh, this is not generative AI. There is no hallucination in this. Yes, there can be false positives and false negatives. That depends upon the underlying data. And luckily for us, we have a huge amount of digitization in radiology. We have a huge amount of not huge, but a fair amount of digitization in pathology. So those are the places where we have good databases and where we have been able to do good things. And the AIMS model is extremely robust. And of course, you have to keep on rechecking it just like you would for any test. So you would keep on rechecking it whether it is missing something or it is not missing something or it is picking something which is not there. So that is true like for any other medical device.
So there's just one thing I was wanting to ask about custom GPT. Now, my major work right now, I'm concentrating on lactation consultation. So when I'm doing a custom GPT, when I upload certain documents and then I want answers from them, so how will I get the answers? I will upload or whatever documents I want. And then when I ask questions like, such and such lady is coming with the problem of painful feeding or not enough milk, then related to that, all the documents that will come out with that.
Yeah.
This is how it should be.
This is happening. This will happen like this only.
Okay.
Even you can put a link to your videos also. I have made such one custom GPT. If you want to see, I want to show that first it will show the detailed description, then a link to my video where I am speaking on that thing only. Okay. This can be done also.
So I can share that video with that person.
Yeah, that patient will click and see.
A written thing. I think that is more effective than giving in writing.
Yeah.
So, for example, today is
your voice is less, sir. Dr. Jalil, your voice is less.
Please speak louder.
Sorry, sir. One more custom video apart from the one madam has asked. Today is the World Tobacco Day, madam. So just create one awareness video. Let us see how you generate.
Okay. Let us see.
Dr. Ramamurthy, the practical tools what you were saying, one is Digi Yatra. When you enter the airport, it just scans your face and you enter it. When you keep your phone in your front, it just recognizes you. That is your deep learning model. It has learned what you can see. This is another just example. What else you want to ask? You wanted to ask something.
No, at present, actually, as Gaurav told, everything is not validated. It is on the pipeline. That is for our routine clinical use in the OPD, number one. Number two, for both the experts, are any specific GPT models or anything specific, medical specific, not a generic LLM, you are using for radiology images or dermatology images to get the, like a clinical decision support system. You are using you both for getting the diagnostic aspect, diagnostic support aspect.
The AI doc,
Not the generic Chat GPT, Gemini, and Claude. I'm asking specifically any specific like for like IDOC or like open source evidence like that. Any specific thing you are using?
that's what I'm saying. AI doc and all those are coming inbuilt in the CT scan.
Okay.
It's not like I am using. It's a paid thing. When you are taking the license with that CT scan machine, it is already there. It will flag at 11 o'clock. CT scan is done. That this should go right now to the radiologist, and this can be wait till the morning. This is already there.
Okay.
So there are models, there are apps available. Like for example, I was trying to share here. I don't know if it's visible easily. It's just a sec. It's called Model Dermatology app. That's a dermatology app which is specifically trained. But again, these are not validated, so you cannot say that you cannot use them for actual diagnosis. You still have to use your brain. There is another one called AYSA, AYSA, and then there is there is one for. There's another one, paid one, I'm forgetting the name. So there are a lot of tools. The most important thing which Harsh just said was very importantly was that dermatology is a problem because our skin tone is very, very different from the skin tone of the Western audience. So we may not get very good results. And just to add to this, we had done a certificate course of artificial intelligence, and we were told to make a project there. And then we did a project on trying to differentiate fungal infection from non-fungal infections. And when we tried to put in the Indian skin, the results were terrible. So we had to retrain our model. And when we retrained the model, we trained it using a database of Indian skins. When we did that, the results dramatically improved from like 70%, we went up to 85, 90%. So it's very, very important that we have Indian data, and all of us are the people who will create database in India so that it can be done. Dr. Deepak has been telling me that it's time to get to the fun part, which is getting some of the tools, and let's see whether they are going to be validated or they're already validated.
Yes, Gaurav, I am online with you now.
Yes, please.
So friends, we have two demonstration, very interesting case. I don't know, some of you know about how to do this ROP screening without the camera, just doing just like a Doppler. So we have a very interesting from a person, Forest Health, Mr. Jain from Forest Health. Mr. Jain, are you there? So start sharing your screen and start your presentation.
Thanks, Doctor. This is Zain this side from Forest Health. Let me just share my screen. Here, because we are doing it to the online, it is a bit difficult for me to show how the product looks like. So I'm just taking an opportunity to just show it on the browser. So this is the device which we have, we have two models called Trinetra Neo. This is the Trinetra Neo, and we have one more which is called Trinetra Neo HD. So the difference is it looks slightly different from each other, but on the grounds, both does ROP screening. Trinetra Neo does 120 FOV. When I say FOV, field of view, and Neo HD does 150 field of view and angiography, basically fluorescent angiography. So that's the difference. So I'd like to show you before I start the video how exactly this is done, so that you can relate it. I'm just running a video. This is done in so first we basically first. So basically we dilate the eye, we put the speculum, we have a gel, we put the gel and then place the camera on the baby side. I've just muted so that you don't hear the baby crying. So once you place the camera on the eye, so you see the retinal image. So it's a high FOV field of view image. Now the traditional way of seeing by the ophthalmologist is by the indirect ophthalmoscope, where they see only just like 30 FOV, and that will also will be inverse. So they have to just remember what they see and they have to draw it on a paper. So they cannot say show it to parents or the other doctors what exactly they have seen it and how it looks like and how it is supposed to be and what can be done to that. So imaging does a lot of ease to the doctors. Basically, they see the whole eye, 120 or 150 FOV. They see the ridge. They can explain the parents better, counsel it better. The images can be captured by non-ophthalmologists. It can be shared through cloud to the ophthalmologists, get their opinion. There is an AI built in the software itself, which will say there's a risk of ROP, yes or no, as of now. So this is how the screening is done. Post screening, they just put antibiotics so that they before starting the screening, they put the anesthesia drops to numb the eye. They take the anterior imaging like this. This is just for the record purpose that there is no infection and the dilation is done well, and they start the screening. So they do both eye, right and left. When they do screening, basically they have some areas to be covered. They have to take all the areas, which is called central, zone 1, zone 2, zone 3, superior, inferior, and anterior. So that doctor can make sure that there are no ridges or any ROP or flesh diseases in any part of the eye. Very important is the temporal side, which is zone 3, which you can see now, which is at the extreme side of the eye. So this is how the screening is done. This whole device comes in very portable size. So you can see here, it just comes in a small cabin size suitcase. It can be taken and move around the different hospitals. You have just need a laptop. You can just place a laptop and connect the device. You're okay to work. Now I'll just show you how the application looks like. I'm just launching an application. I'm demonstrating you a Neo HD right now. I have a Neo HD with me. When you launch the application, it will go to the home screen and where we register a baby. This is very important in medical legal purpose also. There are many cases, hope a lot of doctors would have come across that they have been sued after 18 years, 20 years and things like that. So this documentation helps doctors just save themselves that they have a digital images of that time that there was no ROP or there was ROP, and they have given the information parents to undergo the surgery and things like that. So here we put in all the details of the patient, date of birth, year, age shows up, the gender, birth weight, POG is gestation age, if like 30, 28 weeks and 50 days, and your PMA gets automatically calculated. Then you say capture. So this goes to the live screening here. So I have a probe in my hand. I'm using an artificial eye to demonstrate. So we have to select which eye you're going to screen. I'm selecting the, so I'm using a foot pedal basically where I can reduce the intensity of the light, focus, and we capture the images. So this is how we capture the images.
Sir, but the vessels are not natural vessels, sir.
This is an artificial eye, sir.
Okay.
I'm using an artificial eye to demonstrate here. So once you take the right eye and then you shift to left eye and then take the images. So this is the imaging part of it. So this is all going to be a live, the baby will be there, you have to dilate and take those images. So here you have one more option is, if this is done by the ophthalmologist, before doing a laser, when they found the ROP, they do something called FA, the fluorescent angio. So to just see very well where the blood vessels have stopped, where the laser has to be hit. This is going to be a mono, white and black imaging with the dye which will be injected to the patient, the baby, and we take the images. So here you get to know where exactly the blood vessels have stopped. So what happens is in color fundus, it is very, because there are a lot of other details which will be seen, it is very difficult to see which at which location the demarcation has happened. So this will help them to do a very good laser job. Let me just. So now, thanks. Doctor was saying more about the AI, how it can help, and things like that.
What
So in
is
review,
what does FA stand for?
fluorescent angiograph.
Fluorescent. Okay.
Yeah. So it's here. Fluorescent angiograph.
I just had one question. When
Yeah.
you're doing the actual scanning,
Uh-huh.
that clamp with which you spread the eyelids,
Yeah, speculum. Yeah.
the speculum. So does the machine rest on that, or is the machine directly in contact with the eye?
This the touch will be directly to the eye. So we are using gel. Let me just go back to that video and I'll pause there.
The hand is always obstructing seeing that where it is.
Okay, so I'll show you one more video where I'm not concentrating on the screen. I'm just on the baby's eye. So here, okay, we just clean. Okay, now I think here you can see in this video it is more visible because here I have not kept the
gel. I see.
So you put the gel on the thing and now you place it on the baby's eye. You can see now here in this video.
Yes.
Yeah, this is how it is done.
Okay. So it's in direct contact with the thing, just like an ultrasonogram.
Yes, it is ultrasound, but only thing is we're taking the eye here.
That's right. Okay.
Focus. Like focus.
Yeah. And you can see the operator is moving. So basically, they are changing the position.
It all around the eye.
Yes. So we are moving it. So we have a technique called clockwise. So we make sure we go by clockwise so that we don't miss any of the quadrants, which are very important.
Okay.
Deepak sir.
That's
Deepak
right.
boss. Deepak boss, I think it's this part is not till now. It is just a gadget, not AI. Like our endoscope for the like endoscope for eye. I am using an endoscope for ear examination, and the same thing my ENT specialist uses, not the otoscope, endoscope for the ear examination. We have we connect with mobile and capture the picture and send to the ENT surgeon if needed, or else we treat on our own.
But here it is not a ophthalmologist. It is just an assistant to it.
It is,
Okay,
till
let
now
me,
it is not to do with anything
yeah,
with AI. This is
yes,
just a non-AI subject.
it
Gadget.
is. Yeah, yeah. So I'm still coming to that. I've
Okay.
not come to that
Okay,
topic yet. Post taking images. So what I took was basically the artificial eye. These images are of actual baby's eye. Okay. Of course, there's not one single patient eye, but they are different patients' eye. Okay. Now this is a retinal image. This is a detachment. This is an ROP ridge, which you see here. Okay. This is at the zone 3, and this is a left eye. Now we have a tool called AI here. I just run a AI tool here. Now this AI tool will run and say there is a suspect of ROP. You can see here, suspected risk, yes, and you have low to high risk, and it's saying where exactly is the risk. This is the AI built in the software.
Now it's AI.
Yeah. So now for an example, I'll take the second image. With my best knowledge,
Got it.
It doesn't have any ROP. Now I'll run a AI here. Okay.
Okay.
So this will say suspected no.
Got it.
So we are still doing the next level of ROP, where it will actually say you which zone, what has to be done. So this is again an ROP image. I'll run the AI. It will say suspected yes. It is more on the red because you can see this is basically called heat mapping. Okay. So this AI we have built based on heat mapping. As doctor has very nicely explained that whenever you take an AI, you should be knowing on which babies it has been, which race of the babies which has been this AI has been trained, who has validated, what is the sensitivity of the AI. So I like to just answer a few questions on that. So all the AI model of ours we have trained under Indian babies. So we have trained right now around 600 cases of non-ROP and ROP of 593 ROP cases. So total accuracy on our thing is 98%, sensitivity is 97. So this is the accuracy of our AI right now. Of course, the AI goes better and better with each new feeds we do. So this goes better and better. So this is a very first initiation of our AI. This is going to be with the software itself, because we are promoting. We have presence of ROP cameras in almost 68 countries. We have FDA CE approved. We sell in US, and we have presence in Europe, Central Asia, till Russia, and name the country, we have the devices there. And many countries, including Dr. Anand Vinekar, team which does one of the biggest ROP program in the world is KidRob. They are also using the AI from our thing, and they are using devices from us. They use the cloud platform also. We are connected through the cloud because all their operators are not optometrists or ophthalmologists, not even nurses. So they are all graduates, undergraduates who have been trained how to take the images. They go to the rural places, they go to the government hospitals, they screen it, they run the AI, they send the images to the Dr. Anand Vinekar. He sends back his reviews. So that is how we do end to end. So the whole, it is not only detecting the AI, they do complete closure of the loop as well. Then the patient, if they really need the anti-VEGFs or the lasers, they come to Narayana, they do the lasers there, post-laser. Also the imaging is done just to see whether the blood vessels have grown post to laser, and then they close the case. Any questions? I'll be more than happy to answer.
I had a question, please.
Yeah, doctor.
You say that your machine is being used all over the world.
Yes.
Like you have the AI enabling in the Indian machines, in the machines used in India, is done on the Indian population. So that means that you are doing the same thing in every country on their particular population.
We have a small, size of images which we have taken it from Central Asia, West of Asia, and some of US and Central Asian babies, and we have done as that also. In our image size, the maximum population size is India, and we have trained on the other eye also. So in ROP, to my best knowledge, to detect the ridges, the race doesn't really actually matters, because what changes here is the pigmentation of the retina. If they are Western, they are Caucasian eye, the pigmentation is more lighter. Because of our skin tone, we are slightly on the darker side. That is what actually matters.
But the ridges are detected equally.
Yes. The pathology of the ridge remains the same.
Okay, thank you.
Yeah, doctor. Any other questions?
Any complications you have seen in during the procedure, like any injury to the eye, cornea during?
Touchwood, we have sold around 650 devices across the globe, and we have been selling this from 2016. We have not come across any incidents which has lead to any complications. Yes, one thing what I have personally seen also is, because babies, these are all done on premature babies, so the amount of pressure they put on the eye, we have to be a bit careful. I have seen some sort of hemorrhages if they have applied bit more pressure on the eye, and hemorrhages mostly gets recovered by itself because they are very young. You don't need even any medicine. But to avoid that, you have to be very precise what is the amount of pressure to give. So that happens in the training.
Okay, thank you.
So what kind of licensing do we have for this? Is it like a software as a medical device? Is it like a screening tool? Is it like a diagnostic tool? Or is it only like an assistant to pediatric ophthalmologist? Like,
okay, so as a device and the software, this is just an imaging software and the device for imaging. The AI assist the operator to say whether this has any risk, yes or no, as of now. And post to that, it is always recommended, when the risk is yes, to go through an ophthalmologist, because they are the ones who are going to close this loop.
so is it is the software licensed in terms of it's like a screening tool, or is the software is just like an add-on? It does not. I mean, the device itself is the one that you are marketing, and the
Yeah,
registration
so the
only for the
software,
device.
yeah. So software and the device is bundled.
Sorry, didn't catch that.
The software and the device is bundled.
No, that is true. But as far as the licensing is concerned, you're only having the registration and the approval only for the hardware, and the software is just like a help to this one without any validation by itself, or the
No,
software
it
is
is
also
validated.
validated in any way.
Validated. So when I say device, it has to go through the software validation also.
Okay.
So it has been validated for CE, FDA, and ISO other standards.
Dr. Gaurav, we
Yeah.
faculties will talk to the Chandrasekhar. He's from Bangalore.
Okay.
They are exporting this software and devices to the other countries.
Fantastic.
There is a huge demand.
Yes, yes, I'm sure.
I think we faculties we have to see a live demo. I think that is because this is done with a hurried this thing. Because last time also I could not able to contact Zain. I think he has done a good thing. See, all these are AI enabled for screening. All the learners has to learn, not for the diagnosis.
Yes. No, it's wonderful. I think it's a wonderful thing you have arranged, and I think it sensitizes all of us in a very beautiful way. And I think it's a wonderful device.
Thank you,
I'm so
Jay.
happy that we are a smart academy. We are actually, learning these things, because most of the other courses they're not focusing on these things. They're everything about generative AI. So I think kudos to you, kudos to Zain, and I'm looking forward to the other demo as well.
Thank you, Gaurav. I think I need a critical feedback from all the senior pediatrician. Like, see, whatever the things we learning here is one thing. Second thing is documentation. What is the real world application is the second thing. So we have to create the idea. We have to take the people like Zain and all, the technicians, and we have to tell them, see, we are going to need this and this. See, that is our main motto. Dr. Sham, Dr. Aruna, Dr. Sunita, we are the doctors, we are the main end users. And we have to tell them, we have to use them. Then you have to tell them this is the device which is not doing good. This is not this is the practical. It is not giving like this. Still it is confusion. So we are the one, we have to do it. So that is why nowadays a small clinician can become a researcher by using AI. Earlier it was not, it was limited to the medical college. But you should have that thought that ignition should come from you, not from me. That should be there. I think with this we should thank Mr. Zain from Forest Health. I should thank Chandrasekhar also. Now we move on to Mr. Pulkit. He came to Calcutta.
Excuse
Yes,
me,
yes.
there's just one thing I wanted to know.
Yeah, please, Sunita.
Previously, you all were saying that the images can be taken and sent to an ophthalmologist so many miles away. But here too, the machine itself is telling you that there is a possibility of this or that. So you don't have to send the images then. No? You can send, or you still send the images.
No, madam. One has to be, human should be there always.
So you have to send the baby then.
No, the images.
Madam. See, if Zain, can you add to this?
Yeah. So here what happens is the AI supports you. Can you hear me?
Yes.
Sorry. So the AI assists you, to send the ones which have suspected yes. Okay. So it is filtering down. Instead of a doctor seeing all 10 patients, he sees only the ones which has the issue. So even his workload comes down and he actually sees only what has to be seen.
So you are just going to send the patient. No longer need of sending pictures or anything because
So see what happens is in ROP, I'll just summarize in another 2 minutes. So in ROP, what happens is basically stages 1, 2, 3, 4, 5. So usually till third stage, we don't do any treatment. Okay, we wait because on an average, if the 100 patients you take prematured, between 37 to 50% of the babies will have ROP. But in that 35 to 60% of the ROP patients, the treatment needed is only 8 to 11%. Okay. Maximum of the cases will recover by themselves, but it has to be monitored because we'll not know which baby will recover naturally or which needs a treatment. So this is going to be a screening process every week till the baby is the retina is fully matured.
Okay.
So this on goes on, follows up. So say you see a rich, at zone 3, which is just stage 1. Okay, you just monitor. You just send that image to doctor. Doctor will say, yeah, you screen this baby for next 2-3 weeks. We will see how it progresses.
Okay.
Based on that, then the doctor will see if the stage 3 stops at stage 3 and it is regressing. He will say, get the baby. We will do anti-VEGF or the laser. Based on the condition, they will do it.
Okay. Thank you very much.
Mr.
That
Jain,
makes
I
it
have
very clear.
one more doubt. Mr. Jain, are you an ophthalmologist?
And now I'm basically an engineer by the background, but I'm an application specialist as well. I go and train doctors around the globe.
Fine. I'm a neonatologist who had a practice of more than 4 decades. I have done many, I witnessed many ROP screening by Aravind Hospital here. So the thing is, the ROP is a rapid progressive disease. So screening, I think like what sometimes we may transfer the images MRI in a PAC system, In the PAC system, the MRI images and the consultant will give it in the ICU or like that. There is an option for screening this, put it in the laptop and PAC system and we'll get an opinion from the specialist. Unless it's a rush disease or it requires a laser treatment, immediate intervention is needed.
Agreed.
Deepak, we
Sir,
can go to
oh,
next demonstration. Next demonstration.
Yeah,
Deepak.
thank you so much.
Okay. Deepak.
Hello, everybody. How are you? This is Pulkit Raturi here from Diagnosis team. I'm the Chief Growth Officer. Deepak sir, are we good to start
Yeah.
the session?
Pulkit, please start.
You
Pulkit, please
can
start.
start, sir.
Yes.
It's been a very intriguing discussion with everybody. And I think it's a valid point in time to kind of discuss what Diagnosis has been doing. It's a delight to see what Trinetra is doing. Just allow me a second. I'm going to share the screen. Are you able to see my screen, everybody?
Yes.
yes.
Great. So just going to show you what this tool looks like. Just a second. So just kind of giving you a bit of brief of what the product is all about. Just going to quickly go over it. I believe all the pediatricians already know what the autism prevalence rate is currently. It is steadily growing. So, as engineers, as AI scientists, when we realized, looked at this problem of neurodivergency and neurotypical kids, we realized that there is a big gap that we needed to fulfill. And what we found was the biggest challenge that we were seeing was as Dr. Gupta also mentioned, within the triage, that the screening and early detections weren't happening. So we wanted to support the parents with where the therapy costs can be reduced. There's a timely intervention. And while the neuroplasticity is on a high with the child, we could provide this particular tool to the doctors as an assistive screening tool to kind of assist them with the symptomatic case that they're seeing. So we saw a challenge with subjectivity, with having expertise not there, the time consuming part where the doctor, if refers somebody to the therapy center or to the CDC, with the stigma and the time and the costs involved in it, many parents drop out. They don't end up going. And when the problem has become more severe with the child at the age group of 5 or 6, then it reckons to them that something needed to be done, which we did not do or did not follow on. So here is a story of Sikandar, where the parents, got it diagnosed at the age of 7, and by then a lot of things were missed out. The late diagnosis caused, the early brain development problems, which could have been taken care of, the patterns that have been set in the child, um, and obviously an overall burden for the rest of the life on the parents and on the person itself. So this is what we are focusing on. So our product is something that changed a lot of things. It came out with an Indian demography, with a very low cost turnaround hardware. Uh, but using AI, we created a scalable, quick, cheap, and objective solution. The child is, from anywhere from the age group of 16 to 9 years, but 16 months to 9 years, but 2 years to approximately we ideally say that, okay, 5 or 6 years kids, try and get them to the screening. They just sit in front of the camera. It's a non-invasive technique. And while they're watching a video, their data gets analyzed and the report gets generated. So as you can see, Sikandar is sitting over here with the mother, and because the child is very hyperactive, so it's sitting on mother's lap, is watching the video, and we're capturing some of these patterns that are there in a child: social, geometric, facial recognition, name calling. The parents would come and say, hey, my child has delayed in speech, or when we call the child's name, they don't listen. So we looked at those common patterns, and while the child is watching a video, the AI is doing the magic in the back end. And using eye tracking, head movement, name calling, there are about 17 such parameters that go into the play. The report gets generated in a very soft language. So if you can see, the language over here is not to make parents panic. As Dr. Gupta was also saying that, the false positive, false negative, what is the stigma, what is the pain that the parent is facing. So we actually really could relate to what Dr. Gupta was mentioning, and we have taken care of these things within our product. So our sensitivity and the specificity, we did a research at AIMS Jodhpur. Now this data, the number of patient validity has gone up to about 750. And, our sensitivity and specificity are approximately around 86%, compared to the Inclen or the Cars International that we are using. We compared it, like we did a double blind study on the patients, and we found out that our tool was at par with the FDA approved products, even though we are just a screening tool. So right now, we are the first CDSU approved tool that is there. Obviously, there will be many more to come like us, but in Class B, we are the first autism tool in India to be approved CDSCO. And obviously, right now we are working with Rajasthan government, with NHM, where we are providing screenings through a CSR fund, and we are providing screenings for free to low income and socio-economic backward individuals, parents, where these tests are not possible. So these are some of the plans that we have. I can share more details with you with the doctors, considering what the price plan is. You can see over here what we are providing to the doctors is a one-time cost. As I said, like what Diagnostic saw was, we just wanted to enable something to the doctors, and thereafter there's no AMC, there is no hidden cost, there are no hidden charges that doctors have to pay. Once the product is enabled, it's per screening cost that we charge, and that's it. That's all doctors have to pay to us month on month basis. I'm just gonna quickly show you the tool that is there as I was showing. Can you guys see my screen? Can you guys see my screen?
Yes, sir.
Great. So from the product side, I'll show you. If you can see my screen, it's a very simple camera that has been used for AI tracking and AI training. So we particularly use this camera for the same, and this allows us to provide
camera visible.
the Indian demography. It provides us for a very cheap price to the doctors. So I'm gonna quickly show you the dashboard. As you can see, it's very simple to use. You can have your assessments being looked at, who's the doctor, who's your test admin, who's doing it. You have your billing, you have your clinic over here. These are some basic tools so that the doctors can manage their practice better. Obviously, what's more important is this tool, where I'm just going to give a test. I'm gonna give an age of the child that is above 2 years old, and yeah, here I can add admin. The languages are multiple. We are working on multiple vernacular languages. Right now, it's available in Hindi and English. So I'll just quickly share with you how this calibration works. So can you hear this beep sound? Everybody, can you hear this beep sound?
Yes, 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 we can hear.
Fantastic. So, yeah, just a second. Is my screen visible?
Yes.
Yes.
Okay. It's saying it's paused. Are you able to see the next screen?
No, we are seeing the one with the teddy bear.
Just a second. I'm not sure why is it paused. I'm going to stop the screen sharing is somehow not working. Just a second. I'm going to reshare the screen. It paused the screen for me. Yeah. Can you see the screen now? The
Yes, now we can.
Okay, fantastic. So as you can see, there is a calibration tool that is here, and based on the lights and the camera settings that is there, you can see that it is providing you with the feature which will tell you how to calibrate. So as you can see, as I come in the light, if I move to the side, it will tell me. It's very intuitive. Once the calibration is done, we need to tell the kid to look at the screen so that this calibration can mark the eyes of the child. And the test administrator get this product trained for the doctors. We provide training to the staff that is there. Now, I'm going to show you how accurate this tool is by pretending to be an autistic child. So I'm going to look at the geometric patterns. I'm just pretending that I'm an autistic child and I'm socially awkward. I'm not going to look at people, and so I'm going to look at the ring that is there, the basketball ring or the building that is there. In this case, I'm looking at the train that is upstairs, not at the person in general. This is where the parents have to do the name calling. So the parent will stand at the back and they will call the name of the child and see whether the child responds or not. So this test has got, as Dr. Gupta was mentioning, we have a dedicated research team that on daily basis does data collection, and then we have a dedicated psychologist team to make sure whatever data is being generated are the false positives and false negatives being checked or not. So we make sure that from our end, any child that gets positive test, they get a free consultation with our psychologist who help them out with psychotherapy. So not psychotherapy, but psycho counseling, I would rather say, with the parents, not to feel burdened or pressured why the child has come positive. And if there are false positives or false negatives, we make sure that we check and eliminate those issues, because after all, this is an AI technology. So as Dr. Gupta was saying, that human intervention is very important, and we have kept that in mind from day one. So I completely agree with him that even if AI is being used, you can't beat a doctor's years of experience. So that's why this assistive tool is there to support the doctor or the therapist and not to take over what they are doing, right? It helps them quickly do the screening in OPD itself before sending the parent to a CDC where the parent might not end up going. So when a doctor sees a symptomatic case, we just help with this particular tool. We help them objectively eliminate any chances of, missing out on early intervention. So that's why it is very valid in an OPD. If a doctor, if a pediatrician has got a CDC started, then it is fits very well with the assessment packages that the doctors have created or the therapists have created. So this is a tool that is helpful in creating that. And currently, because there are kids who are very hyperactive, we are working on a shorter version video. So as the presentation was shared with by Dr. Gupta, we are having a dedicated research team that makes sure that even the new models are being trained and validated before they are assigned to the doctors. And when they are assigned to the doctors, there is no hidden charge. Doctors are not asked to pay anything extra. The test charges might be different, but there is nothing where the doctor would have to be feeling surprised that, oh, do I have to pay more for this tool? So we have created the entry barrier very simple and very small for the doctors to start using this tool. And because it's a CDSCO approved tool, we are using it in the camp. We are using it with the NHM Rajasthan. It is working out really well for us. This test is over. I'm gonna show you the results also. It's gonna take a few seconds for the results to come out. But very quickly on the mobile phone, the doctor on WhatsApp will receive this. Now, these are some basic data points. As you can see, it's in Hindi or English. You can toggle, and it'll be in other vernacular languages of our country. But for now, I'm going to skip this part, and I'll show you how quickly the report gets generated. And in matter of minutes, the doctor can witness the report, can see the report, and guide the parent what needs to be done. And they are given free consultations, parents anyways, if the child is positive. So you can see it's uploading very quickly. I can show you an old report meanwhile to give you an idea. Yeah, it's almost done. So this was a report where I pretended to be a neurodivergent or a neurotypical child. So I'll show you the comparison of our report that is there. Meanwhile, if anybody has any questions, you can start asking regarding the product or regarding the tool that is there.
What does CDSCO stand for?
Ma'am, CDSCO is the drug authority of our country, where we are basically we have taken the license for Class B in the product medical device
Can I
category.
add, Pulkit?
Okay.
Yes,
Can I
sir.
add? See, madam, any software which has been made through medical devices regarding screening and diagnosis, no, any model, AI model or whatever this thing, it has to pass through this CDSCO guidelines. Just like it's a central government body, we have to take a license and we have to do it, madam.
What is the cost? Excuse me, what is the cost of this diagnosis software, AI tool?
Pulkit?
Yes, sir. So here, these are the prices that we have. Currently, these are the prices that doctors are being charged. And these are the special rates for the doctors for the pedicon that we have attended, as well as for the this AI conference, this AI course that sir is doing.
I am based at Bikaner, Rajasthan.
Okay, lovely, sir. I'll pass on my contact.
I am a friend of Dr. Dhananjay Mangal.
Oh, great, sir. What a delight.
Dhananjay
What's your
Mangal is a very astute pediatrician from Jaipur. Very close. He is very much active in
I think
telemedicine now.
his son has contribution in this.
Yeah.
Okay.
It is mainly a study from IIT Jodhpur, sir. Sorry, IIMS Jodhpur.
Okay.
See, why I included this diagnosis or autism detection? Because of excessive use of mobiles and all.
Yes.
Nowadays, autism cases have been increased. I think all of you can agree with me.
Yes, sir.
So we, the common pediatrician, should know how to screen these babies and send it to the counselors for the, early the treatment in autism, the better is the outcome. Hardly medication will help. It's a stimulation therapy.
Okay.
So with the use of if you have a more case, you can develop your own child development center and you can use this. So that is why these are all the things we should think like in a broader way, like what are all the things which are there commonly. So that is why I included this topic. Thanks, Mr. Pulkit, for demonstrating. You have one more batch also in the next week, Saturday, Sunday. I will let you know. Anything more you wanted to demonstrate?
Yeah, I just wanted to show the accuracy of the product. As I mentioned to you that I was pretending to be a neurodivergent, neurotypical, a special needs child. So I was not looking at the person. So the accuracy of the tool can show you clearly that where I was looking at the train or whether I was looking at the basketball ring, or whether I was looking at the geometric pattern. I just wanted to show to the fellow doctors that the accuracy of the tool is very good. But what I completely agree with Dr. Deepak and Dr. Gupta is that AI is there to assist us. And that is what we've been trying to tell to the doctors, that it cannot replace you, sir, ma'am. It can assist you. It can reduce the time of turnaround with a patient. And it can also help a patient without breaching their privacy or asking them too many questions, which is what generally these MCHR, ESA cars, they do. The parent's child can be screened by using this tool. So as Deepak sir was saying, it has got a very good flow in the OPD. It has got a very good flow in CDC now. So I would highly recommend, I've shared my number in the chat group. If any one of you would like to know more or would be interested, I'd be happy to communicate and contact with you in person regarding this tool. And absolutely, I think what is more important for us is, as the prevalence rate of this particular population is growing, neurodivergency and we are working on ADHD and dyslexia tool as well. But like I said, as Dr. Gupta mentioned, again, I keep referring back to the presentation by the core team that has been given, that we are very particular about the sensitivity and the specificity. So dedicated research team has been put just for this, to make sure that our product stays competitive and validated in the market. So if any one of you have any questions regarding the products, what's coming up, I'd be happy to answer that at a personal level. I've shared my number as well in the chat.
Thank you, Pulkit. I think better to get one-to-one demonstration during your free hour. And I have taken the demonstration from a child psychiatrist from Bangalore. Pulkit, what's her name? From Bangalore.
Anusha.
Anusha. She is from Andhra, but she is in Bangalore. So she is going to show you and discuss you. So these are not much big investment for a pediatrician, but it will augment your once in a week. You can make the cases to come to your clinic and you can do the follow-ups, and most of the things you can train yourself, the rehabilitation. Only the severe autism cases needs a child developmental center. Most of the online courses are there to learn about child developmental, because stimulation therapy works a lot in autism, that I am doing it. So that is what the idea. I think all of you are in my group only, academy. We have made a separate group. It's called demo group. Pulkit, Zain, all those people are with us till This course is not ending only now, because we'll be in touch. We are in a community now. Dr. Jalil, Dr. Sunita, each and everybody is a part of this academy for the need of the poor people of India. We have to develop a low-cost tools, AI tools, so that our Anganwadi workers, community guides, common pediatrician, medical officers can detect and refer. Early referral, early, the child will become all right, and it will become a good, strong human being. And that is what our health of our youngsters and adult India will develop. So we, the pediatricians, are stakeholders. So one or the other way, we pediatricians are the stakeholders for the health development of our country. See, that is my intention. Thank you very much, Pulkit. And I think 7:20, all the people are listening to this practical demonstration. Thank you very much. RCP won the toss and started batting. So no matter who wins or who loses, that is not mean to us. Let the best team who plays well will win the trophy, IPL. Both of them have a equal this thing. Though I'm a Karnataka, I don't like I usually go for the talent. The way Vaibhav Suryavanshi is playing, in my prediction, AI prediction, and I put it in the Gemini and Claude, it is telling more than 1 lakh runs he is going to achieve by the end of 35 to 40 years. He will become the god mode, super god mode of cricket. I don't know if he maintains his stability and health and fitness. I think with this, if no more question, I need a critical feedback from all seniors like Dr. Sunita, Jalil, how we can improve our course. See, only my ideas, I can't do anything. I need ideas to improve for the next batch or anything, any additional things. I can host a separate webinar. There is no problem. With this, the other batch is also over now with the Zoom, no hazels and all. Thank you very much for your giving your time for learning. Yes, Jalil sir.
Sir, excellent. These two demos are excellent. One is ROP and ASD. I just asked Mr. Pulkit whether you have this hygienosis in a community ground for a screening. Say, for example, 1 year, 6 months onwards, the ASD incident is picking up. So, have you used this wonderful tool to diagnose early pickup in the community?
Right. So, sir, very, very apt question. And I appreciate you been asking some very good questions all throughout the seminar. I must acknowledge that. Yes, as I mentioned, that we are working with NHM Rajasthan. So we have started going to Anganwadis and started doing free screenings for these kids. So just to give you an example, every week we are screening over 200 kids in Rajasthan, in Jaipur alone. So what we have done it recently at Faiz-e-Aam, which is a very well-known madrasa over here. We have done it in all the Anganwadis that are there, and we have received tremendous support. We see that people are aware of what is happening to their child. So they are showing interest in making sure that these early interventions are happening. And we have started a campaign called Screening Sahi Hai campaign, which you will see very soon, which is pointing towards telling parents and educating them, then go to your doctors and talk to them. If you're not going to talk to your parents, to your doctors about what's happening to your child, you might miss out on a big opportunity on helping your child. So that campaign is going out soon. And the other one is Growing Right campaign that we have started. So we look forward for that. I hope, Dr. Jalil, that helped answer your question.
One more thing, the screen positive kids, have you interpreted the MChat or confirming or assessing the severity?
So internally, yes, we are doing grading and scoring. But as I mentioned, we have a dedicated research team and a psychologist team. So we are first validating on how accurate they are compared to the gold standard tools that are there. And once we are fully satisfied, then in the report, you will also start seeing gradings. like mild, medium, severe. So you will see the Indian standard grading.
So basically,
What
it's a
in this
diagnostic screen.
Sorry, please go ahead. Yeah.
Basically, the iGenos is a diagnostic tool.
It's a screening tool, sir.
screening tool?
Sorry,
It's a
screening tool.
Yes.
What I was worried about is what about the false negatives? In this situation, so it becomes very dangerous.
Yeah. So, ma'am, that's a very good question again. And as I mentioned, that we have a team of psychologists that make sure that the false positives are checked. But in terms of false negative, we have dedicated three of our onboarded psychologists to start reviewing and on regular basis look at the false negative claims as well, right?
Okay.
Because we don't want anything to fall out of the crack. So
In
absolutely.
any AI model, Dr. Sunita,
Yes.
there is echoing. Sorry. In any AI model, false negative is cannot be taken into it's a very serious matter. We are going to miss the cases. So that is the very valid question. See, this is the type of question we doctor used to ask these vendors, the model developer team. So then only we'll come to know. Just like in representatives, we ask the researcher, literature, where it has been tried. We try with the academic group. See, that is why this comes. So nowadays, most of the AI models, though it is FDA approved, more of it's a screening models, not the diagnostic one. That we have to remember. See, we the doctors who are the one who are going to make the diagnosis. Only AI will augment it. So that is the main victim.
Even the doctor can pick up below 1 year.
So yes, so Sham, that doesn't mean that we have to see what are the things which are developing.
Right.
Is there any center in Eastern India that is using this tool?
In Eastern India, ma'am, I was recently. No, we have communicated with a few doctors in Assam and in West Bengal, where we are starting trials with the doctors, and we proud to say that military hospital in Jorat has shown keen interest in bringing this tool to the foray for the army personnel and their families. So
there are so many developmental institutes mushrooming all over, everywhere. But I think if you contacted them, then they would really be able to do their work better.
Right.
Because many of them are not really doing very good work. They are just, they are called, but when everything is detected so late that you just make money on the people coming and going all the time. Actual work is not being done.
It's for business, madam. Business it is.
Yes, exactly. So I think I would give you the names of a few institutes in my town and elsewhere. You should contact
Deepak.
Absolutely, Dr. Sunita. That'd be amazing. That'll be a blessing. Yes, Dr. Jalil.
Sham sir, anything you want to ask?
Hey, I just wanted Dr. Jalil also ask the same. How lower age group? How much lower age group can we go with this instrument? Up till which age group?
Great
1
question.
year, 1.5 year, because it needs cooperation.
1 year. So 1 year. Yeah, it's basically 16 months onward. The AIMS Jodhpur research that we had done was the age group was the cohort was from 16 months to 9 years.
Okay.
Ideally, what we felt was that a child 2 years old who can sit on its own and can do this from 2 years to 5 years, which is the median, which is what we have shown. If we capture it during this time, we have a very good chance on giving this child a very good future, and obviously saving the cost for the parents on their pocket. So that is the ideal age group from 16 months to 9 years. Yes, but we say okay, 2 years is when the parents start realizing that okay, there is a speech delay or there is some sort of challenge that my child is starting to face. So that's why we say that otherwise you have to sit with the child. So if the child can sit on its own, I think that's the most unbiased scenario that you can get.
Okay, thank you.
I will suggest Deepak sir, since we were in IAP, in the early, there is a chapter for developmental chapter. Is
Yes,
there,
I know, sir.
and also it is going to come as a AA chapter also, combining with. You can involve this wonderful tool, screening tool, and make a module and see that it is spread across the country. And you be the novel, the advisor for this, and we will put it across to the my president, that is Singaravelu and Neela Mohan, and we will create one platform for this.
Yes,
I think
and we
Dr.
will get
Jalil,
so much more data that way. You know,
Sunita madam, 1 minute. In Tamil Nadu, you must have known Shiva Prakashan.
Yeah,
He
sir.
was
He's
my
like,
co-EB.
I'm about to tell like that. You tell me, sir.
You get him contact with Pulkit. I think you start from Tamil Nadu, sir. We will be with you.
I'm very much interested, and this is a one devastating area which we are coming across. Point in late diagnosis of ASD.
So talk this Pulkit number and talk with Dr. Shiva Prakashan. He is the good person, better than me, to scale this product and do the wonderful work along with IAP.
Sure,
so
sir.
that that's what. Yes, Sunita madam. You wanted to ask?
all. That's all. I think this is, if we do it over the country, we will get so much data to, clearly say this is positive and this is negative. And I remember during your lecture when you were telling us about this product, you had said that only after 4 years you can use it. But he's saying 16 months.
No, we can use it at 16 months, madam. Only thing, eye to eye contact, that digital, no? These babies will be moving around and all.
Yes.
So that biases will become. They have to sit stand like that. 1.5 years is okay.
Earliest
because they are glued to the videos. When you put it on, they don't look anywhere else. They look only at the video.
First they will train the baby, then they will put it, madam, usually.
Okay.
I will discuss.
Take 2-3 settings.
I will discuss the issue with some of our developmental pediatrician, especially with the Shiva Prakasam and all. Then we will come out with a good. Thank you. This is a wonderful platform.
Okay, I think I'll go now. Good night. Thank you. Very interesting.
On instruction of
Sir,
Deepak, I
good
went
night,
to
sir.
the stall.
Sir,
I
good night.
remember at Calcutta.
Good night. Wonderful.
Good night, sir. Good night.
Good night.
Thank you, sir.
Good night. Good
Thank
night.
you for the doctor.
We need
Sir,
some more help
actually, I
from you.
wanted to say, we have a neurodevelopmental pediatrics department in our hospital, headed by Dr. Sanjay sir. Now Dr. Rajendra is in charge of it. I think we will do an RCT study to validate this autism screening tool, so that we can apply it for the entire country, sir.
We would be very interested to know the results after your RCT.
And Dr. Aruna, I vouch for it. If you need any help regarding this, we'd be happy to participate and gather data with you. So if any of the doctors are then implementing it in their practice is interested in working with us on the research part of it as well, please do let us know. We'd be very happy to take this up other than practically implementing it. Thank you so very much.
Mr. Pulkit, kindly share your contact details, please.
Sure, sir. Sure.
In the WhatsApp group.
Sure, sir. I will share.
Good night. Good night.
Thank you, everybody.
Good night, sir. Yeah.
Thank you. Thank you.